Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Harm Reduction is Part of the Treatment Continuum, Normalizing Addiction Through Patient-Centered Care to Improve Outcomes and Reduce Overdose Deaths. And our presenter is Dr. Ramsey, Associate Chief of Addiction Medicine for New York State OASAS. She'll be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursday program. And now it's time to start the presentation and welcome Dr. Ramsey.
Hi, everyone. Thank you for joining us. I'm going to go over the learning objectives briefly before we get into the content of this particular course. So the first learning objective is describe the integration of harm reduction practices within healthcare and improve provider skills in assessing patient readiness for treatment, particularly when working with patients with histories of prior healthcare stigmatization and trauma. Describe low-threshold, evidence-based interventions to reduce overdose deaths, including distribution of naloxone and use of fentanyl test strips. Describe best practices in primary care for implementing and sustaining medication for opioid use disorder services and enhancing retention and care. And reinforce best practices in primary care when working with people who use drugs, including screening and referral for hepatitis C and other substance use associated medical issues. So first, let's discuss understanding harm reduction, stigma, and assessing readiness for treatment. So what is person-centered care? So this is a lengthy definition from SAMHSA. I'm not going to go through every detail, but I think what's important to understand is that person-centered care focuses on the patient who we were working with at that moment in time. So it should be person and family-centered planning that's a collaborative process with our care recipients. So in other words, they should be involved in the development of their treatment goals and in the services provided. And that way, the person's individual goals that they hope to accomplish through their care with you are then incorporated into the treatment planning and engagement. So effective person-centered care planning strengthens the voice of the individual, builds resiliency, and fosters recovery. Harm reduction is a strategy that is employed in person-centered care. What is harm reduction? So these images talk a little bit about what is encompassed within the concept of harm reduction. Harm reduction means respect, dignity, and compassion, and harm reduction focuses on safety, self-efficacy, and independence to help people achieve their individualized recovery. Harm reduction is ubiquitous in our lives. We may not think of it as harm reduction, but all of the following are examples of harm reduction in other areas of our lives: using sunscreen, using seatbelts, abiding by speed limits, using birth control, and the addition of filters to cigarettes. What is harm reduction? This is the official definition of harm reduction, which I will read. Harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. It is based on a strong commitment to public health and human rights. So what are some of the principles of harm reduction? So harm reduction is a set of practical strategies by which harm related to illicit substance use is reduced. Here are some of the key principles of harm reduction. It recognizes that substance use is common. It includes a spectrum of strategies, anywhere from safer use for the person who is not interested in decreasing their amount of use to abstinence. It is low threshold, and the entry requirements are appropriate to the group that's being targeted for services. And it ensures that people who use drugs have a real voice in the creation of programs and policies. Some additional principles. Substance use-related harms cannot be assumed. People who use drugs are more than their substance use. Their substance use is just one of their attributes. Targeting risk and harms to people who use drugs, understanding the roots of their risks individually, and tailoring interventions to reduce them. Accepting people who use drugs as they are and treating them with dignity and compassion. Protecting the human rights of people who use drugs. Acknowledging the significance of any positive change that people who use drugs make in their lives, and maintaining transparency in decisions about interventions, as well as their successes and their failures. So what does harm reduction mean for people who use drugs? Here are some more key concepts. Meeting people where they are at, not forcing people who use drugs to be where you want them to be, and not leaving them behind if they don't meet your expectations. Harm reduction lies, again, on that treatment continuum, with active use at one hand and perhaps sustained abstinence from one substance or all substances at the other end. Abstinence is one of many possible goals. Change is positive. Embrace it and encourage self-efficacy and resilience. Keeping patients alive is harm reduction. So a patient using buprenorphine intermittently to decrease heroin use is harm reduction, as it decreases the risk of death by overdose. From the Iowa Harm Reduction Coalition, dead drug users don't recover. So let's talk a moment about the continuum of use. Not all use is necessarily harmful or equals a substance use disorder. Somebody could have use, so modest use of a substance, whether alcohol or illicit substances, and this may be done without leading to adverse health or other consequences. Not being abstinent may be a reasonable goal for some patients. At-risk use or potentially harmful use. This is more frequent use, leading the clinician to be concerned for either the health effects or other potential medical or psychosocial consequences for the patient, and patient education plays a key role here. So let's talk a little bit more about that continuum with respect to harm reduction. So what other goals may exist with respect to harm reduction? So it does effectively decrease illness, disease, and death. So it decreases the incidence of bloodborne diseases such as HIV and hepatitis C. It decreases the incidence of injection-related infections, so abscesses, endocarditis, et cetera. And it decreases both fatal and non-fatal overdoses. Harm reduction also increases engagement in services and care. It is often the gateway to substance use disorder treatment and medical, mental health, and social services. It's important that we always remember that recovery is individualized. So this is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. There are 4 key components that are involved in recovery. Those are health, home, purpose, and community. Health, so that can be overcoming or managing one's diseases or symptoms. So for example, somebody who's actively using, who has hepatitis C, who is treated for their hepatitis C and cured of their hepatitis C, maybe that person may be more interested in addressing their substance use disorder after their hep C has been treated and cured because they've received empathic care. Home. So if a person doesn't have a stable and safe place to live, it's hard to prioritize other things in their life. So for many of our patients who are unstably or unsafely housed or are homeless, helping them find a place that they can call their own certainly will contribute to them having more of a chance at defining their individualized recovery. Purpose, meaningful daily activities, and the independence, income, and resources to participate in society. So many of our patients don't necessarily feel purposeful in their lives. So helping them find things that are meaningful to them can help them, again, to focus on what they would like to achieve in their life. And then community. So having relationships and social networks that provide support, friendship, love, and hope. Often our patients have unhealthy or codependent relationships or even harmful relationships. So helping them find community with persons who can support them on their road or trip in their life to their recovery. So where do prevention and harm reduction intersect? So when we think about prevention and harm reduction, these also exist on a continuum. With respect to primary prevention, this is the prevention of the initial use or the delay of initial substance use. With respect to harm reduction, it is more typically involved with secondary prevention and tertiary prevention. So with secondary prevention, this is early detection of or reduction of substance use once problems have already begun. So again, helping people, if they're actively using, to use more safely. For example, by distributing naloxone and or fentanyl test strips and engaging with them on safer use. With respect to tertiary prevention, this is reducing substance use problems or harms to prevent further deterioration or death. For example, this could be a syringe service program linking someone to hepatitis C treatment so that they can be treated and cured of their hep C before they develop more chronic liver disease. Let's discuss stigma. So stigma towards people who use drugs exists in healthcare settings. Research indicates that stigma contributes to a host of adverse outcomes for people with substance use disorders, including the following: poor mental and physical health, non-completion of substance use treatment, delayed recovery and reintegration processes, and increased involvement in risky behavior, for example, needle sharing. Healthcare providers, unfortunately, have high levels of stigma and bad feelings towards people who use drugs, in part from derogatory or dehumanizing language that is commonplace in the healthcare setting. Studies indicate that the language used corresponds with providing poorer treatment. What we say and how we say it matters. Bad language perpetuates stigma. On the left-hand side is a report back on a study that was done by the Recovery Research Institute at Massachusetts General Hospital. What they did was they provided individuals with 2 paragraphs with identical text, except for the word substance abuser was used to describe a person with a substance use disorder in 1 paragraph. And in the other paragraph, they used less derogatory language. So they described a person with a substance use disorder as just that, a person with a substance use disorder. What they found was that in the instances where the words substance abuser were used, it increased the likelihood of evoking more punitive attitudes. So in the context of people reading this paragraph, when the term substance abuser was used, they were more likely to be viewed as less likely to benefit from treatment, more likely to benefit from punishment, and more likely to be blamed for their illness. And these results have been confirmed by additional studies. So it's not just a matter of being a police officer for language, but it really does affect people's outcomes. On the right-hand side is one example of recommended language not to use when speaking about persons with substance use disorder or substance use disorders. So I think of it as you can get rid of most of the A words that have historically been used. So words such as addict or alcoholic or abuser. Instead, use person-first language, such as a person with a substance use disorder, a person with an opioid use disorder. With respect to the words clean and dirty, it is often common parlance that is used in support group meetings, such as 12-step meetings. However, in the context of healthcare provision, we should never be using the words clean or dirty either to describe a urine toxicology or to describe a person with respect to their time using and their time not using. So we would not consider describing any other person with any other diagnosis besides substance use disorder in this sort of derogatory way. So instead of using these terms, for example, you can have an unexpected urine toxicology result or an inappropriate urine toxicology result or an appropriate or an expected urine toxicology result. In addition, you can describe persons as currently not using or as currently using instead of using these terms. Some other terms are a little more controversial, so I'm not going to spend a lot of time focusing on them, but my recommendation is to do a Google search, and there are many, many different versions of how to use appropriate language when describing persons with substance use disorder that you can find online. So let's talk about the historical approach to substance use disorder treatment, and I think of this as the stick. So historically, change was considered to be motivated by discomfort. In other words, if you make people who use drugs feel badly enough, they will change. People must, quote, hit bottom, unquote, before they are ready for change. Someone who continues to use is in denial. The best way to break through the denial is through confrontation. Effectively, people don't change unless they have suffered enough. So, quote, you better or else, unquote. So if the stick is big enough, then no carrot is needed. Let's look at a quote by William R. Miller, PhD. Strong evidence suggests that direct, forceful, aggressive approaches are perhaps the least effective way to help people consider new information and change their perceptions. Such confrontation increases the very phenomenon it is supposed to overcome, defensiveness, and decreases clients' likelihood of change. So let's discuss a better approach to substance use disorder treatment, and you can think of this as the carrot. People in general are ambivalent about change, and that's regardless of whatever change we are talking about, whether it's to lose 15 pounds or whether to take a walk every day, etc. People who use drugs continue their substance use because of their ambivalence. All change contains an element of ambivalence, and resolving ambivalence in the direction of change is a key element in motivational interviewing. Motivation for change can be fostered by an accepting, empowering, and safe atmosphere. Person-centered approaches enhance motivation and reduce risk. Why don't people change? It's not that they don't want to see, in other words, denial, or that they don't care, no motivation. They are just in the early stages of change. How do people change? Change is a natural process. Treatment can facilitate that process. A person's perception of how likely it is that they can make a particular change is a good predictor of whether the actual change will occur, i.e., they have to believe in the change. So the provider or counselor or facilitator's beliefs can become self-fulfilling prophecies. What comprises readiness? A multidimensional concept that incorporates several constructs, including problem recognition, desire for help, desire to change, treatment reluctance, which may be due to fear or privacy concerns, and treatment readiness. And what influences treatment readiness? There are predisposing characteristics. These are static, unchangeable attributes of individuals. For example, gender, race, ethnicity, age, education level, and treatment history. There are illness factors. So these are overall health beliefs, perceived value of receiving treatment, tangible barriers such as lack of transportation, inability to pay for care, or lack of child care, severity of substance use disorder, and legal involvement. And there are inhibiting factors. These are circumstances in the overall environment that interfere with health-related actions. So these are mutable, changeable characteristics which affect mental and physical health, social relationships, and employment, such as depression, social support, familial influences, having a trade, and employment status. What is motivation? So from the Council of Philosophical Studies in 1981, Motivation can be defined as the probability that a person will enter into, continue, and adhere to a specific change strategy. From Miller and Wolnick in 2013, motivation to initiate and persistent change fluctuates over time regardless of the person's stage of readiness. From the client's perspective, a decision is just the beginning of change. So let's look at the historical view of motivation. It is a static client trait. Either the client had it or the client did not have it. The provider, counselor, facilitator has no influence on it. The view of motivation as static led to blaming clients for tension or discord in the therapeutic relationship. So clients who disagreed with diagnoses, did not adhere to treatment plans, or refused to accept labels like alcoholic or drug addict were seen as difficult, manipulative, or resistant. How about a more modern concept of motivation? It is a key to change, it is multidimensional, it is dynamic and fluctuating, it is influenced by the provider's, counselor's, facilitator's style, it can be modified, it is the facilitator's task to elicit and enhance motivation. Lack of motivation is a challenge for the therapeutic facilitator skills, not a fault for which to blame our clients. So as I mentioned, motivation is multidimensional. So what does that mean? Motivation includes the client's internal desires, needs, and values. It includes external pressures, demands, and reinforcers that are both positive and negative. These influence clients and their perceptions about the risks and benefits of engaging in substance use behaviors. Two components of motivation predict good treatment outcomes: the importance clients associate with changes and their confidence in their ability to make changes. So is the client ready, willing, and able to make changes? Ability refers to the extent a person has the necessary skills and resources and confidence to make a change. Willingness is linked to the importance a person places on changing, how much the change is wanted or desired. And ready represents a final step in which the person finally decides to change a particular behavior. Our task is to help the client become ready, willing, and able to make change. So what roles do self-efficacy and resilience have in this process? So what is self-efficacy? From Albert Bandura, self-efficacy is the belief in one's capabilities to organize and execute the courses of action required to manage prospective situations. Self-efficacy is a person's belief in his or her ability to succeed in a particular situation. And from Hira, confidence is a nondescript term that refers to strength of belief, but does not necessarily specify what the certainty is about. Self-efficacy is having the confidence in one's ability to deal with a situation without being overwhelmed. What is resilience? First, a definition of resilience, and then a second definition of psychological resilience. These are both from the APA. Resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress, such as family and relationship problems, serious health problems, or workplace and financial stressors. Psychological resilience is the ability to mentally or emotionally cope with a crisis or to return to pre-crisis status quickly. Resilience exists when the person uses mental processes and behaviors in promoting personal assets and protecting self from the potential negative effects of stressors. So when we think about resilience in our clients, how is it built and when is it built? What plays a role in resilience? So there are both genetic and epigenetic factors. So genetic factors include the diversity of genes and polymorphisms that are associated with neuropeptide Y, the hypothalamic pituitary adrenal axis, and the noradrenergic, dopaminergic, and serotonergic systems, and brain-derived neurotropic factor. Again, these are primarily all within the central nervous system. There are also epigenetic factors. So these are functional modifications to the genome without actually changing the genetic sequence. So in other words, these are expressed differently. And these can be a consequence of exposure to stress-related factors during critical periods of development. So on the right-hand side, what are some of those developmental and environmental factors that can play a role in building resistance? So in addition to the genetic and epigenetic factors, there is the person's sex and gender. There's a process called inoculation. And again, there's that hypothalamic pituitary adrenal axis programming. Those all play a role in the building of stress resilience for adolescents. In addition, there's a developmental process over the timeline of our lives from pre-adolescence through adolescence and then into young adulthood that again encompasses many factors in our ability to build our resilience. They have to do with larger social, structural, economic, political, and cultural environments. So this can be the interface or intersectionality that an adolescent experiences from the neighborhood, school, the family, etc. So not only is resilience built by all of these both internal and environmental factors, but it can also be built or learned. So on the left-hand side, in looking at resilience, it looks at all the components that play a role in a person building resistance. So those have to do with self-esteem, learning from your mistakes, understanding and acceptance of your own strengths and weaknesses, self-control, willingness to overcome difficulties rather than trying to avoid problems, optimistic thinking patterns, social skills, and the ability to seek assistance from others, ability to recognize your own emotions and those of others, problem-solving skills, and goal setting with realistic expectations. So in order to build that from childhood, it requires having positive role modeling from those around you, which could, again, be in the home environment, the school environment, after-school environment, and other facets of your life. The more modern definition of resilience includes these components. So they title it Advancing Despite Adversity. So in other words, having goal orientation and working towards your vision, being proactive, not waiting for adversity to happen, and both large and small everyday challenges. So they see there being 6 domains of resilience, and they include the following: vision, which includes purpose, goals, and congruence of your vision and what's able to be accomplished. Composure, so being able to regulate emotions. Interpretation bias, so understanding what your personal bias is in situations and then interpreting it, using that as part of your interpretation. Being able to be calm and in control. Reasoning, so having problem-solving skills, being resourceful, and being able to anticipate and plan effectively. Health, which comprises nutrition, sleep, and exercise. Tenacity, so having persistence, realistic optimism, and being able to bounce back when things don't go your way. Being able to collaborate, so having support networks, a social context in your life, and being able to manage your own perceptions and the perceptions of others. So what are some of the vulnerabilities for developing substance use disorder? So our genetic predisposition comprises the majority of our vulnerability. So between 40 to 60% of our risk for developing substance use disorder comes from our genetic predisposition. So if we have any history of any substance use disorder, regardless of the substance within our family history, that increases our risk. Also, concomitant mental health diagnoses play a role. So the mental health diagnoses most commonly associated with developing a substance use disorder include bipolar disorder, any form of anxiety, major depression, ADHD, specific personality disorders such as borderline personality disorder and antisocial personality disorder, and antisocial conduct disorder diagnosed in adolescence. A history of trauma and/or abuse is very common among persons who develop substance use disorder. So for females, particularly pre-adolescent sexual trauma, and for both males and females, being a victim of or a witness to violence. Often poor coping mechanisms or escapism are part of particularly the initiation of substance use. Impulsivity also plays a role in the initiation of substance use, and that could be impulsivity due to an adolescent brain, in other words, the prefrontal cortex, that is sort of the marker of adult maturity with respect to brain development, hasn't yet occurred in an adolescent, and often substance use starts in adolescence. There are also specific substance use disorders that are associated more with impulsivity, such as bipolar disorder and borderline personality disorder. Sensation and novelty seeking also play a role in the initiation of substance use, but by the time someone meets DSM-5 criteria for a diagnosis of a substance use disorder, generally speaking, they are not enjoying their substance use any longer, but rather are driven by a compulsion to use over which they have no control. Environmental triggers and sensory cues often trigger someone to use or to resume use. And then the more formal definition is a lack of homeostatic reward regulation or reward deficiency. So this is an orientation towards pleasurable rewards, meaning dopamine surges. And often when we prime our brains in adolescence with early substance use, we actually get anatomical reworking of neural pathways and a change in the physiological balance of neurotransmitters in the brain, both of which orient the brain towards seeking out and desiring those dopamine surges, which are not physiologically replicable with activities that we would normally get pleasure from, such as eating some food we liked or having sex. So the rewards or dopamine surges that are received from illicit substances, or really any substance that causes euphoria, are much, much more intense than those dopamine surges that we get normally, physiologically speaking. Another thing to assess in our patients is adverse childhood experiences. These have a significant impact on health outcomes, both with respect to physical health outcomes as well as mental health and substance use disorder outcomes. So those adverse childhood experiences include physical, emotional, and sexual abuse in childhood, physical and emotional neglect in childhood, and household dysfunction experienced by the child. So things like mental illness in a parent, incarceration of a parent, substance use in a parent, a mother treated violently, or divorce or separation of parents. And again, these have significant consequences not only on epigenetics, as I mentioned in an earlier slide, but these also disrupt neurodevelopment, and they can lead to social, emotional, and cognitive impairments, the adoption of health risk behaviors, and then ultimately leading to, as I said, physical diseases, mental illnesses, and or substance use disorder diagnoses, as well as social problems, and actually can cause early death. Trauma plays another large role in our patients' lives. So it's important to understand how trauma leads to changes in the brain and how this impacts our patients. So a traumatic experience elicits an immediate physiological response that has long-term effects on the brain. So during a stressful situation, and this is whether a person experiences directly a violent experience, for example, or witnesses it, or it happens to someone they love, or they are exposed to it, say, for example, through their job, say as an EMT, then they get an immediate response that is in various parts of the brain. And so the brain releases neurohormones, which are basically our fight or flight response. And additionally, our adrenal glands, which are located near our kidneys, release adrenaline and cortisol. And this induces a fight, flight, or freeze response. And then the cortisol that's released actually elicits long-lasting stress responses and shuts down the release of neurohormones. So this occurs in multiple areas of the brain. So the anterior cingulate cortex is involved in our rational decision making, and it appears smaller in people that actually have a diagnosis of PTSD or post-traumatic stress disorder. The hippocampus is also involved. This has a role in long-term memory formation, and this also appears smaller in people with PTSD. And the amygdala, which processes memory and emotional reactions and is overly responsive in people with PTSD. We also need to remember that trauma can intersect with our patients in multiple roles within their lives. So a survivor of trauma may have experienced myriad types of trauma in their lives. Perhaps they're formerly incarcerated. Perhaps they belong to the LGBTQ+ community. Perhaps they are a Black, Indigenous, or person of color, so from the BIPOC community. Perhaps they live with a disability. Perhaps they have a reading or writing disability. Perhaps they're homeless or unstably housed and are currently either on the street or in a shelter. Perhaps they are an immigrant, refugee, or asylum seeker. So perhaps they are in fear of being here without proper documentation. Perhaps they've experienced trauma as a parent. So perhaps they've had intersections or interactions with the child welfare system, which have been traumatizing for them. So we should be using trauma-informed care in our practices. So what are the 4 R's of trauma-informed care? Realizing the widespread impact of trauma, recognizing signs and symptoms of trauma in people, including in our patients, their families, our staff, and our clinical team members. Responding by fully integrating knowledge about trauma into policies, procedures, and practices, and seeking to actively resist re-traumatization. So what are some of the general principles of trauma-informed care? Treating our patients with universal trauma precautions. So assuming that everyone has experienced some form of trauma and applying these 4 R's of trauma-informed care with all of our patients. Having the ability to adapt or be flexible in a clinical situation. So if something isn't working with respect to our interaction with our patient who may have experienced trauma, we need to be flexible in the context of that visit and change what we're doing so that we're not re-traumatizing our patient. Not assuming that one trauma is all trauma. So we cannot take one person's traumatic experience to a particular situation and extrapolate that to another patient. Every individual patient's experience of trauma is unique. And we should anticipate shame and stigma within our patients. So in other words, seek not to shame them or stigmatize them in our interaction with them, and work with them to build their self-efficacy and resilience in the face of their history of trauma. So let's talk a little bit more about ambivalence and the trans-theoretical model. So again, let's talk about the concept of ambivalence. So ambivalence is normal. People usually enter treatment with conflicting and fluctuating motivations. People want to change, but they don't want to change. So working with ambivalence is the heart of the problem. And counseling depends on the person's current stage of change for each substance. So we can't assume that just because someone wants to stop using fentanyl because they're afraid of fatally overdosing, that they necessarily want to stop using marijuana or cocaine. So when we have mismatched counseling and stage of change, this leads to an ineffective interaction with our clients. So reminding everyone of what the stages of change are. They are pre-contemplation, contemplation, determination, action, maintenance, and then resumption of use. There may be people who permanently enter the cycle as well. And again, we can move fluidly between these stages. So let's talk a little bit about motivational interviewing. What is motivational interviewing? So from Milner and Rolnick from 1991, motivational interviewing is a way of being with a client, not just a set of techniques for doing counseling. From Miller and Rolnick from 2002, motivational interviewing is a directive, client-centered method for enhancing intrinsic motivation for change by exploring and resolving ambivalence. So what is the spirit of motivational interviewing? Let's talk about it stylistically. It explores a client's perceptions without labeling or correcting them. It is not just about teaching, modeling, or skill training. Resistance is seen as an interpersonal behavior pattern influenced by the facilitator's behavior. Resistance is met with reflection. It should be non-judgmental and collaborative. It's based on a client and facilitator partnership. It is gently persuasive. It is more supportive than argumentative. It listens rather than tells, and it communicates respect for and acceptance for clients and their feelings. So when we look at motivational interviewing, let's think about some principles of person-centered care. So I'm not going to read through all of these, but just some key ones. Change is self-change. We, meaning we as the facilitator, don't need to come up with the good ideas. Those should come from our clients. Change requires partnership. Change is not a power struggle, and we cannot take away people's choice about their behavior, even if we don't agree with it. So what are some obstacles in motivational interviewing to effective listening? Warnings and threats, persuading with logic, arguing, or lecturing, asking too many questions, ordering and directing, giving advice, making suggestions, and providing solutions without eliciting those from our clients. So what are some clinical considerations? So as I mentioned, harm reduction is an evidence-based practice that can be utilized within the spirit of person-centered care. So what does that look like? The person sets the direction of the process. I don't want to stop using heroin, but I don't want to die. Give or prescribe naloxone, advise regarding or provide fentanyl test strips. Goals are set that are most important to the person. I am going to use heroin with other people around me and use a clean needle every time. Prescribe syringes or give information regarding a local syringe services program. The person's strengths, abilities, and preferences are highlighted. So you have created a plan that will allow you to use in a safer way. And you can go over Build a Safety Plan, which is a New York State Department of Health publication, with your client in the context of an educational session. And those are available at the website that's listed. You can order 500 copies at a time for free in either English or Spanish. So now let's move into discussing low threshold evidence-based interventions to reduce overdose deaths. First, let's discuss fentanyl-related overdose deaths in the United States. So on the left-hand side, you can see data from 1999 to 2019 with respect to substance-involved overdose deaths. And as you can see, starting in approximately 2013, the darker orange line, which represents synthetic opioids, so this is referencing fentanyl and or fentanyl analogs, has been leading the cause of deaths with respect to overdoses since approximately 2013, with a sharp increase since then. If we look on the right-hand side, we can see overdose deaths have unfortunately increased again in 2019. So they started increasing before the pandemic and continued to increase during the pandemic. So if you notice specifically the column for synthetic opioids, between September 2019 and September of 2020, there was a 55% increase in synthetic opioid deaths, which is obviously extremely alarming. If you look at the last column, I also want to point this out to you because I think sometimes we don't think about psychostimulants. But if we look at deaths attributable to psychostimulants, mainly crystal methamphetamine, again, between the time period of September 2019 and September 2020, there was a 46% increase in deaths due to other psychostimulants, so again, mainly methamphetamine. If we look at data specific to New York State, we can also see that that pattern is replicated in New York State. So you had an increase of deaths starting in September of 2019, and that period from September 2019 to September 2020 is the highest on record with respect to overdose deaths. And if you look at the chart on the bottom, you can see that the vast majority of deaths are attributable to opioids. So again, 85% of deaths from September 2019 to September of 2020 were opioid-involved deaths. This is a visual showing that New York State Department of Health guidance on building a safety plan. So I recommend that you order these for your practice setting and that you discuss it in detail with your patients who are actively using, regardless of the substance that they are using. Remember that fentanyl and/or fentanyl analogs can be added to anything that's purchased on the street. So this is reminding us about fentanyl test strips. So with the current federal administration, they now allow federal dollars to be used to purchase fentanyl test strips. And fentanyl test strips are a well-accepted strategy by people who use drugs to test their drugs before using them to see if fentanyl is present in their drugs, and that they can then modify or change their behavior with respect to how they use or how much they use based on whether they have fentanyl present in the drugs that they are about to use. So this shows some instructions on how to use fentanyl test strips, and federally they have also released guidance on how to use fentanyl test strips. So here is more detail on how to use fentanyl test strips. I'm not going to go through each step now, but you will have these slides to review if you would like to incorporate this in your education with your clients. I also wanted to go over a couple of myths that exist about fentanyl in the media. So one of the myths is inhalation exposure risk for fentanyl. So this comes from the American College of Medical Toxicology. At the highest airborne concentration encountered by workers, an unprotected individual would require nearly 200 minutes of exposure to reach a dose of 100 micrograms of fentanyl. So again, this would be extremely unlikely. What about dermal exposure risk for fentanyl? Transdermal delivery systems or patches take 3 to 13 hours to produce a therapeutic serum fentanyl concentration and 35 hours to reach peak concentration. If bilateral palmars, so the surfaces of both of your palms, were covered with fentanyl patches, it would take approximately 14 minutes to receive 100 micrograms of fentanyl. In addition, fentanyl patches are optimized material matrix to absorb to the skin versus powdered drugs sitting on the skin. So it is unlikely that unintentional skin exposures to tablets or powders cause rapid toxicity. So this is to reassure particularly emergency response personnel who may inhale fentanyl or have dermal exposure to fentanyl at a scene, that likely what's happening is the anxiety around that potential exposure is causing them to experience physical effects, not due to fentanyl exposure. So what are the risks for overdose for people who use drugs due to COVID-19? So using alone due to social or physical distancing put people at increased risk for overdose because no observer was present to give naloxone, leading to more fatal overdoses. There were also increased triggers for relapse or resumption of use, with increased mental health symptoms and despair due to social and physical isolation. So what were some innovative practices in the delivery of substance use disorder services during COVID-19? These included virtual naloxone trainings, mail order naloxone and other harm reduction supplies such as syringes and fentanyl test strips sent directly to the homes of people who use drugs. An example of that service is at www.nextdistro.org, and the Never Use Alone Overdose Prevention call line at 1-800-484-3731 or at that website. This is if a person is opting to use alone, they can call this hotline and someone will remain on the line with them while they're actively using. And if the person using becomes unresponsive at any point, then the Never Use Alone person would then call 911 and have EMS sent to that person who had overdosed. With respect to OASAS, in our opioid overdose prevention during COVID-19, we created an overdose prevention landing page at that website. We also have a video on overdose prevention, and just a reminder that there is the OASAS 24/7 Hope line, which can be either called or texted for persons who are interested in accessing substance use disorder services. So a reminder about the best practice of dispensing and or prescribing naloxone. So just a reminder, naloxone is an opioid antagonist, which reverses opioid overdose. It is easy to administer. It is inert when opioids are not on board. What that means is that it is not contraindicated in any medical situation or in any situation where somebody may have a certain medical condition or be on any medication. Because again, if there are no opioids on board from a physiological perspective, then the naloxone has no interactions with any other substances. So it is imperative that naloxone is in the hands of people who use drugs, who actually do the most reversals, though they're not documented the most. Obviously, the most reversals that are documented come from EMS, police, fire, et cetera. And then just an example of how you can prescribe naloxone, which again can be prescribed by anybody who has prescribing privileges in New York State. So you can write intranasal naloxone, which is 2 milligrams per 2 mLs most commonly. And then the SIG or instructions for that would be to spray 1 milliliter, 1/2 of a syringe into each nostril upon signs of opioid overdose. Call 911, may repeat once if no response within 2 to 3 minutes. But again, if you give 2 doses and there's no response, you should be calling 911. And refills, you can put up to 99 refills. I would like people to be familiar with the NCAP program. So this is the Naloxone Co-Payment Assistance Program. That is a program through the New York State Department of Health. So many pharmacies dispense naloxone either under a standing order or by prescription. And the NCAP program covers up to $40 in naloxone co-payments with health insurance coverage. Here are some harm reduction resources. The Harm Reduction Coalition is a national advocacy and capacity building organization that works to promote the health and dignity of individuals and communities who are impacted by drug use, and their website is listed. And there's the New York State Department of Health, Office of Drug User Health, and their website is listed as well. Now I'm going to talk about best practices for medication for opioid use disorder or MOOD services, and enhancing retention and care. So why MOOD? So MOOD reduces heroin, and we can extrapolate that to fentanyl overdose deaths. So as you can see on this graphic, as more patients were prescribed buprenorphine and methadone, heroin overdoses declined. So MOOD very effectively decreases person's risk for both fatal and non-fatal overdoses. So what are the goals for MOOD, and what are our MOOD options? So the goals for MOOD include decreasing the risk for fatal and non-fatal overdoses, eliminating opioid withdrawal syndrome, decreasing opioid cravings, increasing patient functionality, and again, goals as defined by the patient, helping to normalize those changes due to opioid use to brain anatomy and physiology, and decreasing transmission and acquisition of viral infections such as hepatitis B, hepatitis C, and HIV, and infection complications such as abscesses, cellulitis, and endocarditis. The 3 FDA-approved medications to treat opioid use disorder are the following: methadone, which is an opioid full agonist and must be dispensed from an opioid treatment program, or OTP. Methadone is associated with decreased mortality for persons who have opioid use disorder. Buprenorphine is an opioid partial agonist. It is a Schedule III drug. Just recently, after the new federal administration came in January, buprenorphine no longer requires mandatory education to acquire a DEA X waiver if your intention is to prescribe for less than or equal to 30 patients. buprenorphine is also associated with decreased mortality for patients who are on it who have opioid use disorder. Naltrexone is an opioid antagonist. It is not a controlled substance, but notably, it is not associated with decreased mortality when prescribed for those with opioid use disorder. So if we look at the mood research on pharmacotherapy for opioid use disorder, the data on methadone and buprenorphine are pretty similar. So patients on methadone were over 4 times more likely to stay in treatment, and 33% had fewer opioid-positive drug tests compared to patients with placebo or treated with sugar pills. Methadone treatment significantly improved treatment outcomes, whether taken alone or when it was added to counseling, and long-term, beyond six-month outcomes are better for patients receiving methadone, regardless of whether they received counseling or not. Buprenorphine treatment significantly decreased the number of opioid-positive drug tests. Multiple studies found a 75 to 80% reduction in the number of patients testing positive for opioid use. And methadone and buprenorphine are equally effective at reducing opioid use. No differences were found in opioid-positive drug tests or self-reported heroin use when treating with these medications. So this is data that I pulled from reviewing multiple studies over many years on MOUD. Let's talk briefly about the mechanism of action for MOUD and about mu opioid receptor activity. So first, let's discuss full agonists. So full agonists refer to those opioids that fully activate the mu opioid receptor. So heroin, any other opioid, full agonist opioid, which can be misused, which includes all opioids, essentially except for buprenorphine, including methadone, which is used for opioid use disorder treatment. You can think of a full agonist as there will be an increase in effects due to the drug without abatement. So the more you take, the more effects you feel, until if you took enough, you would go into respiratory depression and you could fatally overdose if not reversed with naloxone. In contrast, buprenorphine as a partial agonist is pharmacologically very different from full agonist opioids. So it has what is termed a ceiling effect, and that ceiling effect has several effects. So one, the ceiling effect makes buprenorphine safer than full agonist opioids. So it limits the possibility of respiratory depression in persons who are already opioid tolerant or opioid dependent. In other words, they already have an opioid use disorder. So it is safer, and when it's combined with other potentially depressive medications, such as benzodiazepines, again, buprenorphine is a much safer alternative than a full agonist opioid. In addition, when people who are opioid tolerant or opioid dependent or have opioid use disorder take buprenorphine, they do not feel euphoria associated with it. So this is very different from full agonist opioids in which they can feel euphoria. What this means is that those emotions or feelings that that person who's been using opioids has been masking for a long time by using or misusing full agonist opioids, they are not going to feel those, have those blockage of feelings when they take buprenorphine. So it's important to warn patients about this when they start on buprenorphine, because they may experience memories or feelings or emotions that they've been masking for a very long time, and that may feel very uncomfortable. So for example, if they have untreated depression or anxiety, that may actually become worse when they start buprenorphine rather than better. So it's important to counsel patients around that so that that's an expectation that they have. And if those issues come up for them once they're stabilized medically on buprenorphine, then any other issues can be addressed. And then finally, there are antagonists. So antagonists refer to both naloxone, which reverses opioid overdose, and naltrexone, which again is a treatment for opioid use disorder. So antagonists actually block the mu opioid receptor and don't activate it at all. But another important thing to be aware of is that antagonists also block the effects of endogenous or internally released opioids, which also contribute to our happiness, for example. So when persons stop using opioids, full agonist opioids, their baseline dopamine level returns to a level that is lower than what their baseline level was before they started using. So that is inherently associated with dysphoria or a depressed mood. So again, naltrexone, by blocking the mu opioid receptor and blocking endogenous opioids, can actually contribute perhaps to a depressed mood or increased dysphoria. So this is reinforcing the point that I made about the ceiling effect of buprenorphine. So a consequence of that is that buprenorphine is by far the safest opioid. And you can see this because its death rate is far, far lower than those attributable to other opioids. So in other words, somebody is not going to overdose. An adult, particularly an opioid-experienced adult, will not overdose from buprenorphine alone. Not to say that if they didn't have other substances on board, such as full agonist opioids, then perhaps buprenorphine could be present in somebody who died of an overdose. But buprenorphine alone is a very safe drug. In 2019, New York State OASAS and the Department of Health released a best practices document on prescribing buprenorphine, and I'm going to go over some of those key points in the document. So prescribers should ensure continued access to buprenorphine even in the absence of counseling. Prescribers should ensure immediate and continued access to buprenorphine for patients who at the time may be unwilling or unable to participate in counseling or other formal psychosocial services. It's far more important to stabilize someone medically with buprenorphine and decrease their risk for overdose. As I stated earlier, if someone has additional needs which may emerge after stabilizing them on buprenorphine, the patient themselves may be more willing to participate in counseling. But again, that should be patient-driven and should not be enforced by the prescriber. Prescribers should not discharge patients solely based on the use of prescribed or unprescribed substances, including but not limited to cannabis and benzodiazepines. As I stated earlier, whether someone is using prescribed benzodiazepines or taking benzodiazepines illicitly, it's far safer for them to be doing that with buprenorphine on board than with a full agonist on board. Prescribers should ensure continued access to buprenorphine even in the presence of other drug use. Prescribers should strive to minimize diversion, but not allowing concerns for diversion to prevent them from treating opioid use disorder. So as I mentioned, it's far safer for someone to be using benzodiazepines or Z drugs such as zolpidem or other benzodiazepine-like drugs that are used to treat insomnia. What happens is their overdose risk for persons with opioid use disorder using benzodiazepines or Z drugs is at least partially mitigated by buprenorphine treatment. So again, far safer for our patients with opioid use disorder to be using benzodiazepines with buprenorphine rather than using benzodiazepines with full agonist opioids, which puts them at a high risk for overdose. I also think it's important to help people understand the use of diverted buprenorphine. Concern about diversion of buprenorphine is one of the #1 stated reasons by prescribers for not prescribing buprenorphine. So it's important to understand what happens to that buprenorphine that is diverted. So this was a study that came out a couple years ago, and this really helps to dispel a lot of the myths around the use of diverted buprenorphine. So they asked people who were using diverted buprenorphine, why did you use buprenorphine? So the #1 reason of 79% of the respondents was to ease or avoid withdrawal, so opioid withdrawal. So essentially they were treating their opioid withdrawal. The #2 answer was to maintain my abstinence from other drugs. So that was responded by 67% of the respondents. So again, to treat their own opioid use disorder. And the third most common answer was because I knew I would not have access to other drugs for a period of time. So they were not able to access their drug of choice. So they used buprenorphine instead, which, as I stated, is a safer drug than any full agonist opioid that they might have chosen to use otherwise. And the fourth most common answer was because I was trying to wean myself off drugs on my own. So in other words, to treat their own opioid use disorder. When we look at the question of in which of the following ways have you ever obtained buprenorphine, the most common way that people obtained buprenorphine was from their dealer. So actually, instead of acquiring their drug of choice, perhaps, or another drug, they bought buprenorphine from their dealer. The second most common way was from a friend or a relative, and the third most common way was by a prescriber's prescription. Another question, on average, how often did you take buprenorphine when you were using it? In this instance, we see that people are using buprenorphine that they acquire on the street similarly to how they would have used it had they been prescribed it. So the two most common answers are more than once a day or once a day, which are the most common ways that it would have been prescribed had they received it from a prescriber. And lastly, the answers to the question, in which of the following ways have you ever used buprenorphine? By far and away, the most common way in which people used buprenorphine, so 90% of the respondents, was they dissolved it under the tongue. So they took it sublingually, which is how they would have taken it had they been prescribed it. So what are some best practices for engaging people who use drugs? Having a low threshold setting for initiating care. So making initiation into care easy, not making people jump through hoops. So currently, with the current loosening of restrictions in the context of COVID-19 and the public health emergency, people can initiate buprenorphine care remotely, including via televideo visits or even via audio-only telephonic visits. Having open access, so walk-in appointments and same-day access for care. Direct linkage from emergency departments and jails or prisons. Having multidisciplinary teams, including peers and patient navigators. And then having co-located services, so having primary care, specialty care, for example, for HIV and hepatitis C, for mental health, for substance use disorder, all located in one location to make it easy for patients. A common question that I get is, how long should patients remain on mood? So the answer should be long enough. So as long as that patient is receiving benefit from taking the medication, the patient should stay on the medication. It's different for every patient, but we know that relapse or resumption of use rates and fatal overdose rates are higher for short courses of treatment or for no treatment. At a minimum, patients should remain on mood for 6 to 12 months, but in reality, mood is often much longer and it's often chronic. If you think about it, we don't put a time limit on other medications for other chronic diseases. So why are we putting a time limit on mood? Per one study that came out a few years ago, the average duration on buprenorphine treatment at that time was 8 to 9 years. But I think the way that we should think about it is that opioid use disorder is a chronic disease, and like other chronic diseases, may require medication chronically. So think long-term versus lifetime, but not short-term. So think about it like a person with diabetes needing insulin for life to manage their diabetes. So let's talk about best practices for engaging people who use drugs. So I addressed this slide in the previous section, so I'm just going to mention a couple of additional points here. So when we're thinking about co-located services, let's broaden that concept. So in addition to HIV and Hep C, think about adding services for PEP and PrEP. So that means post-exposure prophylaxis and pre-exposure prophylaxis into the repertoire that is done at that co-located service site. And what would a clinic visit look like for a person who uses drugs? So ask about their drug use, assess risk for overdose, and dispense or prescribe naloxone for anyone using illicit substances, regardless of their intended drug of choice. Because as I mentioned, fentanyl or fentanyl analogs can be added to anything that's purchased on the street. Assess their need for pre-exposure prophylaxis or post-exposure prophylaxis. Vaccinate them for hepatitis A, hepatitis B, tetanus, etc., anything for which they may be at increased risk. Test and treat for Hep C and HIV, and if you can't treat at your site, then do a warm handoff to linkage for Hep C treatment so they can cure their Hep C and for HIV management. Dispense or prescribe condoms, refer to a syringe service programs, or prescribe needles and syringes, which is a New York State Department of Health best practice. Make a safety plan, so use that Department of Health, build a safety plan, counsel persons on not using alone. Offer MOUD, buprenorphine, to decrease the risk for overdose. Address any other acute needs of the patient, and above all, listen and be non-judgmental. Ask about substance use. So assume substance use is occurring and normalize it. Ask non-judgmentally with curiosity and be aware of your face and tone. Don't necessarily expect people to be honest with you at first. You have to earn their trust. But most importantly, listen. Everyone has a story that helps you to understand how they ended up in front of you today. And just a reminder that for the first time in, it was either 2018 or 2019, the USPSTF, which is the United States Preventive Services Task Force, recommended screening by asking questions about unhealthy drug use in adults 18 years or older in the context of primary care. So screening should be implemented when services for accurate diagnosis, effective treatment, and appropriate care can be offered or referred. And screening refers to asking questions with a validated screening tool about unhealthy drug use. It is not testing biological specimens such as urine. So how might we recognize substance use? Be mindful of changes in our patients. Could be a change in mood, a change in sleep, a change in appearance, a change in work performance or loss of employment, a change in financial status, such as financial difficulties, change in relationships, the recipient or instigator of abusive or codependent relationships, a change in legal status, such as a DUI or a DWUI, or being on probation or parole, or being incarcerated, a change in use of the healthcare system, so frequent emergency department visits for detox or overdose, admission for cellulitis, abscess, endocarditis, and a change in housing status, such as insecure housing or homelessness. So in our clinician role, think about what is the role of a brief intervention. So it's being empathic and curious, noting those changes. Again, change could be indicating a problem. Most important, listen. So staying quiet is a learned skill. Physicians, and I'm being specific when I say physicians because this isn't the same for mid-level clinicians such as nurse practitioners or physician assistants. Physicians on average interrupt a patient every 7 seconds. Don't be that provider. State your findings, educate regarding problematic use and substance use disorder, advise in a non-judgmental way. So giving advice, like informing someone about what are considered to be normal parameters for drinking, for example, can be done in a way that's not prescriptive, accusatory, or declarative. And then schedule the person for a follow-up appointment with you. And if this is not within your purview, for example, in some primary care settings, then refer that person, if necessary, to someone who has that expertise. So how would you put this all into practice with respect to motivational interviewing and encountering someone with active substance use? Express empathy. So it must be very difficult for you to talk about your heroin use and how it has affected your relationship with your daughter. Develop discrepancy. It sounds like, on the one hand, you want to stop using so you can see your daughter, but on the other hand, you like the way that heroin makes you feel. Adjust to resistance. I hear you saying that abstinence isn't right for you just now. Support self-efficacy and optimism. You have obviously given this a lot of thought and have some great ideas on what may be useful to you. Avoid argument and confrontation. I don't think you have failed because you are here and you want things to be different. So how might you do harm reduction education with a person who uses drugs? Here are some examples of counseling that you could do. I hope you never inject again, but I want to be sure you and your friends know where to get a sterile syringe. Advising them regarding safe syringe disposal. Advise them regarding where their closest syringe service program is, for example. Advise them regarding safer injecting practices to help them avoid complications of injection drug use, such as abscesses and endocarditis. Advise regarding no sharing of any drug paraphernalia. So Hep C is very infectious. All it takes is microscopic blood exposure. So it's not just about not sharing needles and syringes, but it's also not sharing anything that you may use to prepare or use drugs. So such as a straw for sniffing, such as a stem for smoking, such as a cooker, a cotton, water that are used to prepare drugs for injection drug use. Prescribe syringes or let people know about where a syringe service program is. Warn about fentanyl in the drug supply and teach people how to use fentanyl test strips or distribute fentanyl test strips, which, as I mentioned earlier, now can be purchased with federal funds. I want to make sure everyone is aware of ESAP, the Expanded Syringe Access Program. So New York state law allows for sale or furnishing of hypodermic syringes or needles by registered pharmacy, Article 28 healthcare facilities, or healthcare practitioners. So again, anybody who can write a prescription in New York State can write a prescription for needles and syringes for people who are still actively injecting drugs. And as a reminder, this is a New York State Department of Health best practices recommendation. So when we think about, for example, risks of injection drug use, there's a continuum of risk. So whether we're talking about syringe or water. So the safest use of a syringe would be using a new and sterile syringe every single time that you use. The riskiest would be rinsing a syringe with water and liquid soap only if no bleach were available, and then using that syringe with somebody else. So with respect to the water source, the safest water would be using sterile water from a sealed vial, such as are dispensed from syringe service programs. The riskiest would be using water from puddles or other stagnant sources, for example, like toilet water from a public toilet, which may have bacteria, which again, if you're injecting, you could inject right into your vein, which could cause endocarditis or cellulitis or abscesses. When we're talking about safer injection use, let's look at this and drill down a little bit. So why do safer injection practices matter? Because if we don't have safer injection practices and access to syringe service programs, then unfortunately we get HIV outbreaks such as we saw in Indiana and Boston and Seattle. So the Scott County, Indiana outbreak could have been prevented had there been access to syringe service programs, but they were illegal in Indiana at that time. And unfortunately, in the last month or so, Scott County, Indiana shut down their syringe service program because there's a backlash around syringe service programs currently in the United States in some states. So in the Indiana outbreak, one out of 4 people who inject drugs report sharing needles, and only 52% received syringes from syringe service programs, and only 34% received all syringes from sterile sources. So if we decrease people's access to syringe service programs and clean syringes, then unfortunately we end up with more HIV outbreaks and more hepatitis C outbreaks. So an innovative practice that people who inject drugs have used is something called serosorting. So in other words, they serosort with their injection partners to decrease their risk of acquiring or transmitting hepatitis C. So the least transmission among injection drug users is when partners are 30 years old or older and there's no Hep C in the cohort of people using. The riskiest cohort is in people who are less than 30 years old, and if there's any Hep C positive person within the group that is actively using together. So some people may opt to only inject with other persons who are Hep C positive or other persons who are Hep C negative, and persons often do the same with respect to, for example, sex and HIV. So why is it important to test people who use drugs for hepatitis C? So first, let's review the hepatitis C testing recommendations by the CDC, which were updated in 2020. The CDC now recommends one-time hepatitis C testing for all adults 18 years and older and all pregnant persons during every pregnancy. The CDC continues to recommend people with risk factors, including people who inject drugs, be tested more regularly. If we look on the right-hand side, we can see the Hep C incidence in New York State by age and injection drug use status, and this was data from 2017. So we can see that the biggest bump in incidence is among younger people who are injecting drugs. So between the ages of 20 and 29, but you can see there's an increase overall in people anywhere from 16 to 50 years old. But the biggest bump was in 20 to 29-year-olds who inject drugs. So how can we prevent hepatitis C in people who inject drugs? So there are 3 points of intervention. There's before exposure, at the point of transmission, and after exposure. So let's talk about before exposure. So before exposure, we can do hepatitis C testing and counseling with people to decrease their risk of exposure. For example, by instructing them not to share any drug paraphernalia with anyone. We can treat them, for example, with MOUD, so again, to decrease their active substance use and to decrease their risk of overdose. We can employ harm reduction education, so we can reduce transmission from positive partners by educating them on how they use to decrease their risk of transmitting to others. And we can also vaccinate people against hepatitis A and B, which have higher rates in persons who use drugs. And unfortunately, we don't yet have a hepatitis C vaccine, but perhaps we will someday. At the point of transmission, we can educate people to change their injecting, sniffing, smoking, or skin popping behaviors to make them safer and decrease their risk both of acquisition of hepatitis C, but also transmission of hepatitis C if they're already Hep C positive. And again, by reinforcing no sharing of any drug use paraphernalia. And then we can increase access of individuals who are actively using to clean drug paraphernalia. So for example, writing for syringes in needles or referring people to syringe service programs. And then after exposure, we can test people for hepatitis C by testing with a Hep C antibody and a hepatitis C viral load to indicate whether someone currently has active Hep C infection or just exposure that has cleared, and by giving access to hepatitis C treatment with direct-acting antivirals. Again, access to direct-acting antivirals for cure of Hep C should be regardless of whether someone is actively using drugs or not, because the cure rates are exactly the same between those who are actively using drugs or those that are no longer using drugs with respect to hepatitis C. We should also educate people who use drugs on the infectivity of hepatitis C. Hepatitis C is a very hardy virus and can survive for a long time and survives at different durations depending on the type of surface that it is found on. So for example, hepatitis C on a filter that's used to prepare drugs for injection can last a couple of days. Hepatitis C on foil, that again is often used in preparation of drugs, can last again about 3 to 4 days. Hepatitis C on a surface, so say a countertop, can last over 3 weeks. Hepatitis C in a water container, so again, if people are sharing cookers or sharing water in preparing drugs for injection, that can live again about 3 weeks. And hepatitis C in a syringe can survive over 2 months. In order to decrease the risk of infectivity of hepatitis C, if you have a hepatitis C contaminated solution, it needs to be heated for almost 90 seconds and reach a temperature of 144 degrees Fahrenheit for the virus to be at undetectable levels. This is why it's so important to educate folks on not sharing drug paraphernalia. So what about treating hepatitis C in people who use drugs? So the most frequently used guidelines in the United States are the AASLD, it's hepatitis C treatment recommendation. So here are the recommendations for hepatitis C treatment in people who inject drugs. So they recommend annual Hep C testing for people who inject drugs with no prior testing or past negative testing and subsequent injection drug use. And depending on the level of risk, in other words, how risky their behaviors are, individually speaking, more frequent testing may be indicated. Substance use disorder treatment programs and syringe service programs should offer routine opt-out Hep C antibody testing with reflex or immediate confirmatory Hep C RNA testing and linkage to care for those who are infected. And people who inject drugs should be counseled about measures to reduce their risk of Hep C transmission to others. People who inject drugs should be offered linkage to harm reduction services when available, including syringe service programs and substance use disorder treatment programs. And lastly, and most importantly, active or recent drug use or a concern for reinfection is not a contraindication to Hep C treatment. So I've had this question asked of me before, but in New York State, persons who do unfortunately occasionally reinfect with hepatitis C can be retreated for hepatitis C in New York State. And again, the risk of reinfection among people actively using is actually very, very low. It's about 2 to 3% in New York State. So what is a summary of the hepatitis C real-world data in people who use drugs? Regardless of usual care, partial directly observed treatment or directly observed treatment, cure rates, SVR stands for sustained viral response or cure, are the same for people who use drugs on mood across multiple studies, regardless of current injection drug use, recent injection drug use, or a history of injection drug use. Cure rates for people who ingest drugs are essentially the same. Observed in the real-world data, loss to follow-up often is due to an unintentional fatal overdose. Hepatitis C treatment adherence in people who use drugs on mood was comparable to clinical trial treatment adherence rates. Regardless of the DAA, direct-acting antiviral regimen used, cure rates are the same for recent people who inject drugs, regardless of mood engagement and illicit drug use, again, regardless of which drug they were using. So in conclusion, harm reduction practices are effective clinically and provide a patient-centered approach to addressing substance use and related issues with people who use drugs. People who use drugs should be informed about fentanyl test strips and provided with naloxone, regardless of their substance use disorder diagnosis or their substance of choice, to decrease their risk for overdose. Low threshold mood or medication for opioid use disorder offered in the context of the New York State OASAS and Department of Health best practices supports patients with opioid use disorder decrease their risk for overdose and increases the likelihood of their retention in care. Engaging people who use drugs in care, regardless of their interest in treatment for their substance use disorder, decreases morbidity and mortality associated with their substance use by allowing for education and treatment opportunities to minimize medical complications associated with substance use. So I thank you for your attention, and I'm going to turn it back to Dean.
I want to thank our presenter, Dr. Ramsey, for today's program. I hope you will all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.